All right, so let's jump into blepharoptosis.
Okay.
And this is something that's definitely going to come up on your FRCS PLAS-SURG exam.
Yeah.
And basically, it's drooping of the upper eyelid.
Yes.
But specifically, the margin has to be lower than the upper limbus for it to be blepharoptosis.
Right. That's a really important distinction to make both for diagnosing and for the classification.
Okay.
Now, to really understand how blepharoptosis happens and how to treat it surgically, you need to have a really good grasp of the anatomy involved.
Okay, so let's start with the levator aponeurosis then.
Sure.
It seems like that's the key muscle here.
Absolutely. Yeah. This muscle originates from the lesser wing of the sphenoid bone, and then it inserts into a few different structures.
Okay.
It goes into the orbicularis oculi muscle, the skin, and the tarsal plate.
Okay.
And it's all innervated by the oculomotor nerve, cranial nerve 3, and it provides the bulk of eyelid elevation. So that's about 10 to 12 millimeters worth.
Okay, that makes sense.
Better.
So I guess if you have any damage to that oculomotor nerve, you're going to get quite a significant mitosis.
You're going to get a complete mitosis.
Yeah.
Absolutely. Now, here's an interesting fact, though.
Okay.
The levator aponeurosis actually develops from the superior rectus muscle during the 3rd month of gestation.
Oh, wow. I didn't realize that.
Yeah.
And what about Muller's muscle then? How does that contribute?
So Muller's muscle originates from the levator muscle itself and then inserts onto the superior border of the tarsus.
Okay.
This is controlled by the sympathetic nervous system
Right.
and provides a more subtle 2 to 3 millimeters of lift.
So both of these, levator aponeurosis and the Muller's muscle, are important targets when we're thinking about surgically correcting this.
Absolutely. Yeah. The degree of pontosis and the function of these muscles are going to be critical factors in choosing the right surgical approach.
Okay.
Now, we should also mention the frontalis muscle.
Okay.
So this originates from the galeal aponeurosis, and then it inserts into the skin of the eyebrow. It's controlled by the facial nerve, and it elevates the brow, which then indirectly affects the eyelid position.
So unlike the other two, it's not directly lifting the eyelid margin.
Correct. Keep that distinction in mind. Now let's change track a little bit and talk about the causes of ptosis.
Okay.
It can be broadly categorized into true ptosis and pseudoptosis. So
Okay.
true ptosis is an issue with the eyelid itself.
Right.
So a problem with the levator muscle or the aponeurosis, whereas pseudoptosis is something that mimics true hypothesis,
Okay.
but the eyelid is actually normal.
Ah, so it's like a bit of a trick of the eye then.
Yes.
What kind of things could cause that pseudoptosis?
So a classic example is Graves' disease,
Okay.
where the contralateral eyelid retracts,
Right.
making the unaffected side look popotic.
Okay.
You've also got to consider things like hypotropia Duane syndrome in ophthalmos, even things like chronic squinting.
Okay, so taking a good history and examining the patient is going to be really important to rule out those other causes.
Absolutely. Now let's get into the specific types of optosis,
Okay.
starting with congenital optosis. So this is caused by developmental problems in the levator muscle, and it's usually noticeable right after birth.
So what are the key features then that we'd be looking for in a baby with congenital ptosis?
So you'll see a smaller palpebral aperture, meaning the space between the eyelids is reduced.
Okay.
You'll also measure a reduced MRD1,
Okay.
and that stands for marginal reflex distance,
Right.
which is the distance between the corneal light reflex and the upper eyelid margin. So basically it tells you how much the eyelid is covering the pupil.
So the smaller the MRD1, the more severe the ptosis.
Exactly. You'll also find decreased levator excursion.
Okay.
So the eyelid doesn't move as much when the patient looks up and down. And another common finding is an absent supratarsal crease.
Okay.
So that's the fold that you see just above the eyelashes. And this is an important one in congenital ptosis. The eyelid sits higher in down gaze compared to a normal eyelid.
Oh, interesting. Okay.
Yeah.
So that's one way to differentiate it from acquired ptosis then.
Yes.
Why does that happen?
So it's because of fibrosis in the levator muscle
Yeah.
that prevents the eyelid from moving down as it normally would.
Got it. Now, congenital ptosis can also be associated with other ocular abnormalities as well, can it?
Yes, and you need to be aware of these for the exam.
Okay.
Things like strabismus and amblyopia, which is reduced vision in the affected eye, can occur if the ptosis is severe enough to block the pupil.
Right.
Another condition you might see is Marcus-Gunn's jaw winking syndrome.
And what is that exactly?
So it's a synkinesis,
Okay.
meaning an involuntary movement where the upper eyelid twitches or elevates when the jaw moves.
Okay.
And this is due to abnormal connections between the nerves that control the jaw and the eyelid.
Okay, so we've talked about the congenital causes. Now let's move on to acquired ptosis.
Right. Acquired ptosis can be further divided into myogenic, traumatic, neurogenic, and mechanical causes.
Okay.
The most common type that you'll encounter in practice is involutional or senile ptosis,
Okay.
and this is a myogenic ptosis.
So just normal part of aging?
Essentially, yes. It happens because the levator attachments to the tarsus stretch out over time. But here's the interesting part.
Okay.
The dermal attachments stay intact, and this causes the supratarsal crease to rise.
Okay.
You'll also find that levator function is usually still good in these cases.
Okay, good to know.
Yeah.
What about other myogenic causes then?
Another one to remember is chronic progressive external ophthalmoplegia.
Okay.
This is a type of muscular dystrophy that affects the extraocular muscles,
Right.
including the levator, leading to ptosis.
Okay, moving on to traumatic contosis.
Yeah.
Then what's important to remember about this type?
The key here is time.
Okay.
You need to allow sufficient time for recovery after the trauma.
Right.
Ideally around 6 months.
Okay.
This gives any nerve damage time to heal, swelling to subside, and scar tissue to soften.
That makes sense. You don't want to jump in too quickly before everything's settled down.
Exactly.
Yeah.
Now let's talk about neurogenic ptosis.
Okay.
There are 3 main causes to keep in mind: third nerve palsy Horner syndrome and myasthenia gravis.
So all affecting the nervous system in different ways, but ultimately leading to ptosis.
That's right. So third nerve palsy completely paralyzes the levator muscle. Horner syndrome disrupts the sympathetic nerve supply to Muller's muscle.
Okay.
And myasthenia gravis is an autoimmune disorder that affects the neuromuscular junction,
Right.
causing muscle weakness, including in the eyelids.
So with myasthenia, you would see that ptosis get worse as the day goes on or with any kind of exertion.
Precisely. And another key feature is that it improves dramatically with medications like neostigmine or edrophonium.
Okay.
These drugs temporarily improve the transmission of signals at the neuromuscular junction.
So that's a good clue when you're trying to diagnose it.
Yes.
Right. And lastly, then, mechanical ptosis.
So mechanical ptosis happens when something is physically weighing down the eyelid.
Okay.
This could be a tumor in the upper lid or severe dermatocalcinosis, which
Wow.
is excessive upper eyelid skin.
So you'd want to be treating those underlying causes before even considering ptosis repair.
Exactly. Now, once you've identified a patient with true ptosis,
Okay.
the next step is a comprehensive evaluation to determine the best course of treatment.
Right. Because just knowing it's in ptosis isn't enough.
Yeah.
You need to work out all the other details to actually guide your surgical approach.
Exactly. So the first step is to confirm that it's true ptosis and not one of the mimics we talked about earlier. Then you assess the degree of ptosis.
Okay.
And we do this by measuring how far down the eyelid margin sits compared to the upper limbus.
And how is that measured and what does that tell us?
So we measure in millimeters, and it helps us classify the severity.
Okay.
So mild ptosis is 1 to 2 millimeters of descent, moderate is 3 millimeters, and severe is 4 millimeters or more.
Okay.
This helps guide our surgical plan as different techniques are suited for different degrees of ptosis.
And what else is important to assess apart from the degree?
Levator function is absolutely crucial.
Okay.
You need to measure how much the eyelid moves from extreme downward gaze to extreme upward gaze while stabilizing the brow. This gives you a sense of how well the levator muscle is working.
So how do you interpret those measurements then?
So good levator function is greater than 10 millimeters of excursion.
Yeah.
Moderate is between 5 and 10 millimeters.
Right.
And poor is less than 5 millimeters.
Okay.
This information is essential for choosing the right surgical approach.
Now, before any diphtosis surgery, you always want to check for any dry eye symptoms, don't you?
Absolutely. That's a critical part of the preoperative evaluation.
Yeah.
Because any ptosis surgery can worsen legophthalmos, meaning incomplete eyelid closure.
Right.
And that can lead to or worsen dry eye, potentially damaging the cornea.
So what tests would you use then to assess for dry eye?
So Schirmer's test measures tear production.
Okay.
There are 2 types.
Oh,
Schirmer 1 measures basal tear production, and Schirmer 2 measures reflex tearing. We also look for Bell's phenomenon.
Remind me what Bell's phenomenon is again.
So it's the upward and outward rotation of the eyeball when the eyelids are forcefully closed. It's a protective mechanism that helps keep the cornea lubricated during sleep. If this reflex is absent, the patient is at higher risk of corneal complications from legophthalmos.
So if they've got a strong Bell's phenomenon, they're less likely to have problems after surgery.
Exactly. Now, another crucial part of the evaluation is examining the contralateral eye,
Right.
even if it looks normal,
And why is that so important?
because of Hering's law.
Okay.
which states that the levator muscles on both sides receive equal nerve impulses.
Right.
So if one eyelid is severely tryptotic,
Yeah.
the other eyelid may be subtly retracting to compensate.
So if you correct the severely tautotic eyelid, you might actually reveal that there's some ketosis on the other side.
That's right. We call that contralateral ptosis.
Okay.
To check for this, we use Herring's test. So you manually lift the ptotic eyelid to mimic a corrected position and see if the other eyelid starts to droop.
Oh, that's quite clever. So you need to bear that in mind, particularly in asymmetrical ptosis.
Yes.
What else do you look for when you're examining that contralateral eye then?
So you want to pay attention to the lid contour and the crease.
Right.
This gives you a reference point for creating a symmetrical crease on the affected side during surgery. And of course, a thorough ophthalmologic evaluation is essential
Makes sense.
to ensure there are no other underlying eye problems.
Now, are there any particular issues that can complicate ptosis surgery?
Certainly. We've already talked about dry eyes.
Yeah.
Another is hypoplastic tarsus,
Okay.
meaning the tarsal plate is underdeveloped.
Right.
This can make it difficult to achieve good eyelid position after surgery, potentially leading to eyelid eversion.
Okay.
A floppy upper eyelid, often caused by detachment of the levator aponeurosis, is another challenge.
So would you need to use a different approach then in those cases?
You might need to use specific techniques to stabilize the eyelid and prevent complications.
Okay.
Asymmetrical ptosis, as we've discussed, can be tricky
Yeah.
because correcting one side might reveal a hidden ptosis on the other.
Yeah.
And finally, we always need to be mindful of the intercanthal distance, so the space between the inner corners of the eyes.
And how does that relate to ptosis surgery?
So sometimes ptosis can make the intercanthal distance appear narrower than it really is.
Right.
If you correct the ptosis, you might reveal a pre-existing telecampus
Okay.
or widened intercanthal distance.
So you need to warn the patients about that beforehand.
Absolutely. Now let's talk about anesthesia for ptosis repair.
Okay.
Intravenous sedation with local anesthetic is commonly used, especially for less severe ptosis in cooperative patients.
Okay.
It allows for active patient participation, which helps us achieve precise correction.
So they can open and close their eyes during the procedure.
Exactly. This helps us fine-tune the eyelid height in real time.
Okay.
However, when using local anesthetic, we need to be careful not to inject too much.
Right.
Excess anesthetic can temporarily impair levator function, making it difficult to judge the correction accurately.
That's a good point.
Yeah.
Now, once you've assessed the patient, you've decided on your anesthetic, how do you actually choose which procedure to do?
So the most important factor is the amount of levator excursion.
Yep.
Excellent excursion greater than 10 millimeters
Yeah.
gives you more options like aponeurotic surgery or molarectomy.
Okay.
Moderate excursion between 5 and 10 millimeters might lead you towards levator resection or advancement.
Right.
And poor excursion, less than 5 millimeters, typically calls for frontalis suspension.
So you're matching it to how strong the levator muscle is.
Precisely.
Yeah.
And of course, you also need to consider the underlying cause of the ptosis.
Of course, sir.
For example, if it's mechanical ptosis due to a tumor, you would address that first.
Okay, let's go through the specific techniques then.
Right.
Starting with the Fastenella Servat procedure.
So this procedure uses a conjunctival approach,
Okay.
meaning the incision is made on the inside of the eyelid.
Mm.
It involves removing a small portion of the tarsus molars muscle and conjunctiva.
And what are the advantages and disadvantages of that?
So the main advantage is that it avoids an external scar. However, it's only suitable for patients with excellent levator function and minimal ptosis.
Okay.
It's also considered less predictable than external approaches.
Okay, so a bit more limited. What about Muller's muscle conjunctival resection or the Putterman procedure?
So this technique is also suitable for mild ptosis with good levator function.
Okay.
We often use a phenylephrine test to see if the patient will benefit from this procedure.
And how does that work?
So phenylephrine is a vasoconstrictor that also stimulates Muller's muscle to contract.
Right.
We put drops in the eye and see how much the eyelid elevates. This gives us an idea of how much tissue to resect during the procedure.
So you're getting a preview of what the result might look like.
Exactly. Now let's move on to levator aponeurosis advancement, which is a commonly used technique for mild to moderate ptosis.
Right.
This procedure involves accessing the levator aponeurosis through an external incision in the eyelid crease.
And what are you aiming to achieve with this procedure?
So we're essentially shortening or tightening the levator aponeurosis to lift the eyelid. We use a 4.1 ratio for advancement, meaning for every 1 millimeter of desired lid elevation, you need to advance the aponeurosis 4 millimeters.
Why is that ratio important?
It ensures adequate correction and helps avoid undercorrection.
Okay.
Now, if the patient is under general anesthesia, we can use a technique called the gapping method.
And what does that involve?
So we adjust the advancement until there's a specific gap between the upper and lower eyelids.
Okay.
The size of the gap corresponds to the patient's preoperative levator excursion.
Right.
This helps us get the right eyelid height while the patient is still asleep.
So it's a trick for when they're under GA.
Yeah.
Okay, what about external levator resection then?
So this technique is typically used when levator function is fair, between 5 and 10 millimeters of excursion.
Right.
We resect a portion of the levator muscle itself to achieve the desired lift.
Okay.
There are two common methods for determining how much to resect: the Beard method and the Burke method.
And what's the difference between the two?
So the Beard method takes into account both the degree of blepharoptosis and the levator function.
Right.
Whereas the Burke method uses the gapping method we talked about earlier.
So they're the main options for moderate levator function. What if the function is really poor, though?
That's where frontalis suspension comes in.
Okay.
This technique is commonly used for congenital ptosis and cases where the levator is severely weak or paralyzed.
So how does that actually work?
So we create a sling from the brow using the frontalis muscle down to the eyelid, allowing the brow to lift the eyelid.
Okay.
We can use a variety of materials for the sling things like fascia lata, silicone, or Gore-Tex.
So the frontalis muscle is basically taking over the job of the weak levator.
Exactly.
Hmm.
Now, there are two main techniques for frontalis suspension: Crawford's technique and direct tarsal suturing.
What's the difference between those two?
In Crawford's technique, we tunnel the sling material under the skin from the brow down to the eyelid.
Okay.
In direct tarsal suturing, we attach the sling directly to the tarsal plate. Okay.
Any advantage of using one over the other?
Direct tarsal suturing is often preferred
Okay.
because it creates a more defined supratarsal crease and reduces the risk of complications like entropion, where the eyelid turns inwards.
Right. Before we move on, can we just touch upon the potential complications of ptosis surgery?
Of course. Like any surgery, there are risks. Undercorrection or overcorrection are always possible.
Right.
Excessive legophthalmos leading to dry eye and corneal problems is another concern. You also need to watch out for eyelid contour abnormalities,
Okay.
asymmetry of the eyelid creases, and even problems with the eyelashes.
And what about more serious complications?
So those are less common but can occur. Entropion and ectropion, meaning the eyelid turns inward or outward, are possibilities. Extraocular muscle imbalance, conjunctival prolapse,
Right.
and in very rare cases, even vision loss can occur.
Okay, so important to be aware of those and manage them appropriately.
Absolutely. Welcome back to our deep dive on blepharoptosis.
Okay, so we've covered the basics of anatomy, the different types, and the initial evaluation.
Yeah.
Now let's talk about tailoring the approach to some specific scenarios.
All right.
I guess before we even get into the techniques, are there any particular patient factors that might influence our surgical plan?
Absolutely. The patient's tear film status is really important.
Okay.
If they have any signs of dry eye preoperatively, we need to be extra cautious because, as we've said, patient surgery can worsen that.
So would you completely avoid surgery in those cases?
Not necessarily,
Okay.
but you need to have a frank discussion with the patient about the risks and benefits.
Right.
They might need aggressive lubrication or even additional procedures to address the dry eye before or at the same time as the ptosis repair.
So really important to counsel them preoperatively?
Yes.
And are there any anatomical factors that we need to pay close attention to?
Yes. A hypoplastic tarsus, meaning an underdeveloped tarsal plate, can be challenging. This can make it difficult to achieve good eyelid support and position after surgery. You might need to modify your technique or consider using a graft to strengthen the tarsus.
Okay, so those are some general things to bear in mind.
Yeah.
Now let's go through a few specific scenarios.
Okay.
So let's say we've got a patient with classic involutional atosis, good levator function.
Right.
What would your go-to approach be?
So in that case, levator aponeurosis advancement is usually the best option.
Okay.
It's a reliable technique with a high success rate for this type of ptosis.
And what about someone with congenital ptosis with poor levator function?
So that situation typically calls for frontalis suspension.
Okay.
Since the levator muscle is weak, we need to rely on the frontalis muscle to lift the eyelid.
Okay, that makes sense.
Yeah.
What about a patient with myasthenia gravis and ptosis? How does that change things?
That's a more complex situation.
Yeah.
Ptosis in myasthenia gravis is caused by the underlying disease process,
Right.
not a problem with the eyelid muscles themselves.
So would you still consider surgery in those patients?
It depends.
Okay.
The priority is to get the myasthenia gravis under control with medication.
Mm.
If the setosis persists even with optimal medical management, then we might consider surgery.
Okay.
But it's crucial to counsel the patient that the ptosis could fluctuate or recur if their myasthenia gravis isn't stable.
Yeah, really important point.
Yeah.
Let's say we've got someone with asymmetrical asosis.
Right.
What are the key considerations there?
So as we discussed earlier, correcting one side can unmask proptosis on the other side due to Herring's law.
Yeah.
So you need to carefully evaluate the contralateral eyelid and have a frank discussion with the patient about the possibility of needing a second procedure.
So you might even do a small prophylactic correction on the other side.
It's a judgment call, and it depends on the individual case. Sometimes it's better to correct the more severe side first and then reassess the contralateral side later.
Okay, so really careful planning and communication with the patient is going to be key in those cases.
Absolutely.
Let's move on to some of the more specific nuances of Suturing surgery then. When you're doing a levator-aponeurosis advancement, how do you actually work out how much to advance the aponeurosis by?
We use the 4-to-1 ratio as a general guideline,
Right.
but it's not a rigid rule.
Okay.
We need to consider factors like the severity of the toctosis, the amount of levator function, and the patient's desired eyelid height.
So using your judgment and experience to fine-tune it.
Exactly.
Yeah.
An intraoperative assessment is key.
Right.
We make adjustments based on how the eyelid looks and functions while the patient's awake or under sedation.
Makes sense. Now, another really important aspect of apoptosis surgery, I guess, is managing the supratarsal crease.
Yeah.
Why is that so critical?
The supratarsal crease that fold above the eyelashes is important for both aesthetics and function.
Mhm.
We want to make sure it's symmetrical and at the appropriate height to avoid a hooded appearance.
So what techniques can you use to actually manage the crease during the ptosis surgery?
There are several options.
Yep.
We can use an anchor blepharoplasty technique where we suture the levator aponeurosis to the orbicularis oculi muscle and skin to create a well-defined crease.
Mm-hmm.
We can also resect a small amount of orbicularis muscle or use specific suture fixation techniques.
You're choosing which technique to use depending on that individual patient and the shape that you're trying to create.
Precisely.
Mm.
Now let's talk about some tips and pearls for mitosis surgery in general.
Okay, what are your key things to remember?
One important tip is to minimize cautery use during the dissection.
Okay.
Excessive cautery can damage the delicate tissues around the eyelid, leading to more swelling and scarring.
So gentler approach is better.
Yes, especially in this area. Meticulous hemostasis is also crucial.
Right.
Any bleeding can obscure your view and make it harder to achieve precise correction.
Okay, good point. Any specific things to think about with frontalis suspension?
Choosing the right sling material is essential.
Okay.
We have options like autologous fascia lata, which is the patient's own tissue, or synthetic materials like silicone or Gore-Tex. Each material has its pros and cons, so we consider factors like the patient's age, the severity of the stasis, and the potential for revision surgery.
So no one-size-fits-all approach.
Exactly. Now let's talk about potential pitfalls and complications that we need to be aware of during stasis surgery.
What are some of the common ones?
So undercorrection is always a possibility.
Yeah.
We try to avoid this by carefully assessing levator function and using the appropriate advancement or resection techniques.
Mm-hmm.
Overcorrection is another concern and can be more challenging to manage.
Right.
Lagophthalmos, as we discussed, is common after ptosis surgery and needs to be addressed proactively.
And what about more serious complications?
Eyelid malposition, like entropion or ectropion, can occur. Infection is always a risk, although it's rare with proper sterile technique and antibiotics.
Right.
And in very rare cases, there's a risk of vision loss, usually due to damage to the eye structures during surgery.
So some serious ones that we need to be aware of and try to do everything we can to prevent.
Absolutely. Now let's shift gears and discuss some specific case examples to illustrate these concepts and solidify your understanding of ptosis management.
Okay, welcome back. We've covered a lot of ground on blepharoptosis.
Yeah.
Now let's wrap up this deep dive with some more advanced concepts and some frequently asked questions.
All right. Sounds good.
Let's start by talking about botulinum toxin.
Okay.
What role does that have in botulosis management?
So it's not a primary treatment for true ptosis.
Okay.
but it can be a useful adjunct in certain scenarios.
Right.
For example, in patients with contralateral eyelid retraction, like in thyroid eye disease, we can inject botulinum toxin into the levator of the retracted eyelid.
So you're weakening that muscle to try and improve the symmetry.
Exactly. It can also be helpful in managing synkinesis, like Marcus Gunn jaw winking syndrome.
Okay.
By weakening the abnormal connection between the pterygoid muscle and the levator, we can reduce the eyelid twitching associated with jaw movement.
Right. But the effects of the botulinum toxin are temporary, aren't they?
Yeah. Yes, they typically last around 3 to 4 months, so repeat injections are usually needed.
Okay. Um, Another question, I guess, is how do we actually manage postoperative lagophthalmos after we've done a ptosis repair?
Yeah,
I mean, this is a common problem, isn't it? Particularly if they had some dry eye beforehand or we've elevated the eyelid quite significantly.
absolutely. So conservative management is the first line of treatment.
All right.
This includes things like frequent lubrication with artificial tears, ointments, particularly at night,
Mhm.
and even taping the eyelids closed during sleep to protect the cornea.
And what if those conservative measures aren't enough?
In more severe cases, we might need to consider surgical intervention to improve eyelid closure.
Okay.
Procedures like a lateral tarsal strip or a gold weight implant can be effective.
Okay, so there are options for those more tricky cases.
Right.
What about recurrent ptosis then after surgical correction? How do you approach that?
So first you need to figure out why it recurred.
Right.
Was the initial correction inadequate? Did the levator aponeurosis slip? Is there excessive scar tissue? Once you've identified the cause, you can plan the appropriate revision surgery.
So you might repeat the original procedure or you might choose a different technique.
Exactly.
Okay. Let's move on to talk about some of the advances that have been made recently in litosis surgery.
Right.
Um, I guess one of the main things is the increasing use of minimally invasive techniques.
Yeah, absolutely.
Can you give me an example?
So the posterior approach levator advancement
Okay.
allows us to correct blepharoptosis through an incision on the inside of the eyelid,
Right.
minimizing visible scarring and speeding up recovery.
That's a great benefit for the patients.
Yes.
Are there any other sort of notable innovations?
So we're also seeing the development of new sling materials for frontalis suspension.
Right.
Materials like silicone-coated polyester and expanded polytetrafluoroethylene
Okay.
offer improved biocompatibility and reduce the risk of extrusion or infection.
So constantly refining the techniques and the materials to try and improve things for the patient.
Absolutely. Another area of progress is the use of adjustable sutures in ptosis surgery.
Oh, okay. And how does that work?
So these sutures allow us to fine-tune the eyelid height after the initial surgery.
Right.
We can make adjustments in the early postoperative period to achieve more precise and predictable results.
I can imagine that would be a real game changer, particularly in those asymmetrical cases.
Yeah, it's a real step forward. So to conclude this deep dive, I want to emphasize the importance of a really comprehensive approach to ptosis management.
Okay.
It's not just about knowing the surgical techniques.
Right.
You need a solid understanding of the anatomy, the different types of ptosis, and the potential complications. Thorough patient evaluation is absolutely crucial,
Yeah.
including a detailed history, ocular examination, and assessment of tear film. You also need to consider the patient's age, overall health, and aesthetic goals.
So really tailoring it to that individual patient.
Yeah, exactly. And remember, meticulous surgical technique combined with careful postoperative care is absolutely essential for minimizing complications and achieving the best possible outcomes.
This has been a really helpful deep dive.
It's been a pleasure.
Thanks very much for sharing your expertise.
You're welcome.
I hope everyone listening has found it useful, and best of luck with the FRCS PLAS SURG exam.
Thank you.